Hello everyone, welcome to this video where we will be discussing the dermatology recall questions asked in the INI-CET May 2023 exam conducted just a few days back. I hope your exam went very well. I can say that especially for dermatology because I hope all of you had seen the QRP, the regular videos, and had done the tests that were conducted just around the exam, including the Grand Test and the Elite series, because I can very happily say that most of the questions in the exam were asked from those discussions. And I hope the previous year questions also you had seen, because like in every exam in this INI-CET also, there were direct repeats, there were direct topic repeats, and there was actually no questions that were out of the syllabus. For that matter, dermatology is my favorite subject for your exam because they generally don't ask questions from outside of what we have discussed, and most of the students are able to attempt it well, provided they have studied it. Yes, of course, that is always there. So, coming to the first question here, match the following. So, this is a question which is talking about the Woods lamp finding in different diseases. There was a question on erythrasma in the exam last year where again the Woods lamp finding was given. So, this is also a sort of a repeat question, and we often discuss it through our various interactions. So here it is talking about the match the following of the diagnosis: erythrasma, pityriasis versicolor, tinea capitis, and vitiligo. So what are the findings here? Erythrasma, yes, you can close your eyes, close your ears, and still tell me what is the Woods lamp finding. Erythrasma has a beautiful coral red finding on Woods lamp. Pityriasis versicolor, I tell this in every class, PV is PY. So pityriasis versicolor gives a pale yellow fluorescence, which matches us to this option here, that is yellow. Tinea capitis, a very beautiful finding of green fluorescence. So this is what goes here. And vitiligo is a white lesion. The whiteness becomes exaggerated on Woods lamp. So there's a dermal fluorescence which becomes exaggerated. You see these lesions as milky white, which matches 4 with A. Now, which is the correct option here? 1B, 2D, 3A, and 4E, making option B as the correct answer to this question. Findings on Woods lamp have been always important as image-based questions, but now they can also ask you actually 4 questions together in this one, that is match the following. So they are assessing your knowledge of these 4 Woods lamp findings together. In the infections, the important infections which show us a positivity is number 1, tinea capitis, which gives us a green fluorescence here, that is in especially the gray patch type of tinea capitis caused by the microsporum. So remember, G for G, gray patch shows us a green fluorescence. On the other hand, pityriasis versicolor, which is PV, gives us a PY fluorescence. So pityriasis versicolor gives us a pale yellow fluorescence. When you look at the image also, see the image of tinea capitis, you see that the lesion is on the scalp and there is scaling. So when it is a scalp lesion with scaling, you know it is the Woods lamp of a tinea capitis. In pityriasis versicolor, the lesions are scattered, small lesions on the back. So that's another hint towards PV. On the other hand, when you have a finding in the axilla, which is coral red in color, this is a diagnosis of erythrasma. So these images in itself can be asked. Now, in pigmentary lesions, the pigmented lesions like melasma, they become more prominent on Woods lamp. So these lesions become more prominent on Woods lamp. In vitiligo, what you get is an exaggerated dermal fluorescence, which makes these lesions look milky white. So yes, that is what you see in vitiligo. On the other hand, when you have a baby, a neonate with intractable seizures, what is the bedside test that you can do? Now, a baby with intractable seizures, one of the differentials is tuberous sclerosis. And the earliest way to diagnose is to look for ash leaf macules on the skin. Sometimes these ash leaf macules may not be visible to the naked eye, as you can see on the leg of this baby. On the other hand, when you see it in a Wood's lamp, you see this white patch. So again, this milky white color of the ash leaf macule becomes more prominent on Wood's lamp. So you can use it for pigmentary lesions as well as in hyperpigmentary lesions. So this is the beauty of Wood's lamp. Another question that comes from it: what is the critical wavelength? The critical wavelength is 365 nanometer, and we are using the UVA light here. And the glass in Wood's lamp is made of barium silicate with 9% nickel oxide. So that is just another question that you can get from the Wood's lamp. Coming to question number 2, non-scarring alopecia is a feature of. Now this is again a direct repeat from the INI CET November 22 exam. A question on non-scarring alopecia. So this list was asked in the previous exam as well. Yes, the options are different, but the question is same. Now, androgenic alopecia, telogen effluvium, frontal fibrosing alopecia, and alopecia areata. I know all of you know this answer, right? Androgenic alopecia is definitely a non-scarring alopecia. Telogen effluvium, definitely a non-scarring alopecia, and alopecia areata, again a non-scarring alopecia. Now, many of you may not have read this word before, which is frontal fibrosing alopecia. Not often discussed here. So this is kind of a new diagnosis that many of you might have read in the exam. Even if you don't know what it is, sometimes in dermatology, the name of the disease in itself gives you a hint to the diagnosis. Look here, frontal means the patch is on the frontal area. Then it is fibrosing alopecia. Fibrosing means there is a fibrosis happening here. And when there is a fibrosis happening, it will always lead to scarring. So even if you don't anyway know the disease, you can just derive from the name that it has fibrosis. So it's a fibrosing, a scarring alopecia. So this is not going to be our answer. Our answer is going to be option B, that is 1, 2, and 4, which are the non-scarring alopecias. This is a list of the alopecias here which you should remember. The scarring and the non-scarring alopecias. In the non-scarring alopecias, there is a mnemonic that I have given, which is treats. This is trichotillomania, alopecia areata, effluviums, which includes both anagen effluvium and telogen effluvium, then androgenic alopecia, tinea capitis, and the S here are the two smaller, means the rarer found alopecias. We have moth-eaten alopecia in secondary syphilis, and we have diffuse non-scarring alopecia in SLE. Okay, so treats is what you will remember for non-scarring alopecias. Next, we come to the scarring or the cicatricial alopecias. Here you remember BLCDF, where B is for pseudopelade of Brock, a very favorite of the AIMS and the INI CET questions, pseudopelade of Brock. Then L will remember lichen planopilaris and discoid lupus erythematosus. Very important to remember the D here as well as the L. This is discoid lupus erythematosus. So DLE gives a scarring alopecia, while SLE gives a non-scarring alopecia. This difference you should always remember. Then the other C and D's are dissecting cellulitis of scalp, folliculitis decalvans, and frontal fibrosing alopecia, tufted folliculitis. So BLCDF will help you remember the important scarring alopecias. Here, just an extra edge hint is that lichen planopilaris, DLE, pseudopelade of Brock, and frontal fibrosing alopecia, these are actually lymphocytic type. So here in scarring alopecias, depending on the infiltrate, we have lymphocytic and neutrophilic alopecias. So these are the lymphocytic type. On the other hand, dissecting cellulitis of scalp and folliculitis decalvans, these are the neutrophilic type of scarring alopecias. This is just an extra edge point for the INI-CET exams. They may ask it at some point. So remember the lymphocytic and the neutrophilic type of scarring alopecias. Other than that, morphia, where this image of Encoop D. Sauer is a very favorite image. The linear morphia, then we have traction alopecia, burns, and chirion. These are other causes of scarring alopecias. This list is very important. You should just remember the mnemonic. I'm sure you will not go wrong. Coming to question number 3, a very, very favorite of the INI-CET exam. You pick up the last 6 exams. 5 out of those 6 exams will have a question on the immunobullous group of disorders. Very, very favorite topic. Now, coming to the question, a 50-year-old patient on novilumab presented with pruritic tense blisters. Linear deposits of IgG-C3 were seen on the DIF. What is the diagnosis? They have also given us an image which gives us the finding of linear deposits of IgG-C3 on the DIF. But first, look at the clinical feature here. This is an elderly patient with pruritic tense blisters. These keywords, I tell you all the time, are very important. An elderly patient with pruritic tense blisters. There is no way you can go wrong on these keywords. When this is written, the diagnosis is bullous pemphigoid. And the DI findings are further hinting towards this diagnosis. Even if they had not given us the image, even if it was just a text-based question, then also very easy to come to this diagnosis of bullous pemphigoid. Tense blisters tells you that this is a subepidermal disorder. So anyway, this rules out the pemphigus group. So these two options are anyway out. The DIF, further the IgG-C3 at the DEJ, tells you that this is bullous pemphigoid. Dermatitis herpetiformis will have pruritic lesions, yes, but they will be the smaller vesicles which you see on the extensors. Patient will be a middle-aged patient, and on the DIF you see the granular IgA deposits on the DEJ. Okay, so the correct answer to question number 3 is option D, that is bullous pemphigoid. Very, very important question here. Elderly patient with tense bullae and itching, sometimes on a red urticarial base, that can also be mentioned in the exam. And when you see the histopath, on the histopath, what you see? See, this is the basement membrane. So the cleft is below it. That means it is a subepidermal split. So here what you see is a subepidermal split. And what are the inflammatory cells here? Very typically in bullous pemphigoid, we get eosinophils in the infiltrate. Now these eosinophils are seen on the histopath, and these are the cells which you also see in the Zank smear. So this question has also been asked. What is the finding in the Zank smear? In the Zank, we see eosinophils. And the DIF, as mentioned in the question, linear deposits of IgG-C3 on the DEJ. So very, very typical features of BP which you should know. Another point that was mentioned in the question here is that the patient was on an anti-cancer drug. Now, even though more often bullous pemphigoid has a spontaneous eruption, but in some patients it can also be caused by drugs, in which the NSAIDs, certain anti-epileptics, and these anti-cancer drugs are important causes. So this is just like it was or was not written, that's okay. It's not really giving you a hint towards a diagnosis, but also don't get confused because of it. That's it. Now coming to the 4th question, a new type of question that you see in the INI-CET, where you have the assertion and the reason. Again, the favorite topic, which is the immunobullous. Let us see what it is saying. Histopath examination of a patient with flaccid bullae and painful lesions shows suprabasal acantholysis. Okay. Row of tombstone appearance is seen in pemphigus vulgaris and is diagnostic. So let us first have a look at the assertion. A patient with flaccid bullae and painful lesions, we know that the diagnosis is pemphigus vulgaris. Okay, so this is telling us that the patient has pemphigus vulgaris. Histopath shows suprabasal acantholysis, definitely yes. So the assertion is a correct statement on its own, that the histopath examination of a patient with pemphigus vulgaris shows suprabasal acantholysis. No doubt in that. This is correct. Yes. Now coming to the reason. Row of tombstone appearance is seen in pemphigus vulgaris and is diagnostic. Now this is also a correct statement on its own. We definitely see the row of tombstone appearance and it definitely is diagnostic. So on its own, the reason is also a correct statement. But is the reason a correct explanation of assertion? That is what we have to ascertain. Before that, let's have a look at pemphigus vulgaris. Here, the target are the desmosomes, predominantly the desmoglein 3 and 1 are the targets, and what you see is acantholysis leading to the split in the epidermis. The patient presents with these flaccid bullae. Very typically they look like this wrinkled surface. So the patient presents with flaccid bullae and painful red raw erosions over the body. The mucosa is involved, so you can also get oral ulcers, eye, nasal, genital, all these mucosas can be involved. So the patient presents with these typical flaccid bullae and painful erosions and oral ulcers. So the clinical picture is this. Now, when you do the histopath, what do you see? Before you see the histopath, just understand what is happening here. So this is the epidermis where we have the stratum basal cells, and then we have the stratum spinosum over it. So this is the stratum basal and this is the stratum spinosum. Now, we have these structures here which join the cells to each other. So this is what is joining the keratinocytes to each other. And mind you, these connections are also there between the basal cells because those cells also have to be joined to each other. So what is this blue intercellular connection here? These are the desmosomes which join one keratinocyte to another keratinocyte. But there is another structure here which is the basement membrane. So what is joining the basal cells to the basement membrane? What are these connections called? Yes, these are called as hemidesmosomes. They attach the keratinocyte to the basement membrane. Now, what is happening in pemphigus? In pemphigus, the desmosomes are getting damaged. So when the desmosomes get damaged, they will separate the cells from each other. So that is how the cells will happen. There will be acantholysis. What will happen on the stratum basal? The stratum basal cells will also separate from each other, but they will remain attached to the basement membrane because the hemidesmosomes are intact. So these hemidesmosomes are intact, which will keep them joined to the basement membrane, but they will separate from each other. Now, these are the two findings that you see in the histopath. The cells separating from each other is what causes this suprabasal split here. Okay, so this is the basement membrane. You see the stratum basal cells and you see the split above it. So the suprabasal cleft is because of damage to the desmosomes. Yes, and that is what you see in pemphigus. Now, in this image here, you see this row of tombstone appearance where the stratum basal cells are separate from each other but attached to the basement membrane. Now, this finding is what gives you the row of tombstone appearance. So the suprabasal cleft is because of damage to the desmosomes. The row of tombstone appearance is because of the damage to the desmosomes and intact hemidesmosomes. So these two are contributing to the row of tombstone appearance, and these are two classical diagnostic features of pemphigus vulgaris. But is the row of tombstone appearance because of the suprabasal acantholysis? No, that is not because of the suprabasal acantholysis. So is the reason here a correct explanation of the assertion? No. So the correct answer here is that both assertion and reason are true, but reason is not the correct explanation of assertion. So the correct answer to question number 4 here is option B. That is, both A and R are true, but R is not the correct explanation of assertion. A little confusing question here. It is actually testing your concepts of pemphigus. It's actually testing whether you know what exactly is happening in the disease. And this is the type of questions the INICET is known for. They are not testing your rote learning. They are here to test your concepts. So you can call this a little difficult question. Even though it's a direct repeat, it was more of a concept-based question. Now, coming to the next one here. A 26-year-old patient has bilateral lesions on the trunk as shown below. The lesions are minimally pruritic and have scaling on the periphery. Identify the correct sequence. Okay, so the text here tells us that the patient has bilateral lesions on the trunk and they are minimally itchy, plus they have peripheral scaling. Now the image tells us that the lesions are erythematous annular plaques. Okay, so that's an additional finding that we see in the image. What we are dealing with are erythematous annular plaques with peripheral scaling. So this peripheral scaling, even though we are not able to see that clearly in the image, we have this from the text. So when you read this particular line here, that the patient has erythematous annular plaque with peripheral scaling, what do you think? The minute this word annular plaque with peripheral scaling comes in, you know that you are dealing with a diagnosis that is called as pityriasis rosea. Yes, this peripheral scaling and annular plaque are seen in pityriasis rosea. Even though a red annular plaque with scaling can be tinea corporis, it can also be in some patients of psoriasis, not annular, but a red plaque with scaling can be psoriasis, then it can be tinea, then a reddish purple lesion with scaling can be lichen planus also. So there can be multiple diagnoses of a red scaly plaque with, itching. But when you have this word here, that there is a peripheral scaling, you know that you are dealing with pityriasis rosea. And in this question also you see a big lesion with multiple small lesions around it. Even though the typical distribution is not visible in this picture, but when we have the diagnosis, we know it is P. rosea. So what are the question options here? We have pityriasis rosea and lichen planus in the options. We definitely know that this is not lichen planus. Why? Because number one, lichen planus lesions are more purple in color, then the scaling is uniform on the surface, and they are very pruritic. They are not minimally pruritic. So the options with lichen planus can be safely ruled out. Coming to pityriasis rosea, what is the distribution? The distribution is a Christmas tree pattern that is not there in the question or the image, but we know it once we have derived the diagnosis. So the distribution here is a Christmas tree pattern. You do get a peripheral colorative scale, and the diagnosis is pityriasis rosea. So the correct answer to this question here is option A, that is a Christmas tree pattern with a peripheral colorate and pityriasis rosea. This is what you see here. The first lesion that the patient gets is called as the mother's patch or the herald patch, and then 1 to 2 weeks later you get these multiple lesions along the lines of cleavage in a typical Christmas tree pattern, as you also see in this image. So this pattern is a very important hint towards diagnosis of P. rosea. And when you look at the lesion closely, you see this red annular plaque with a peripheral collarate of scaling which has a free edge. So this is a very typical lesion of P. rosea. The patient is classically asymptomatic. There is no itching, but in some patients, especially when it is a drug-induced P. rosea, these lesions can have some pruritus. And our question here says minimal pruritus. So don't get confused reading about pruritus. Don't think it could be lichen planus. When you see that these are red annular plaques, when you read that there is scaling on the periphery, please be sure that you are dealing with P. rosea. Okay? Because lichen planus is completely different. These are purple pruritic lesions, and there are these lacy reticulous stria on the surface which are called as Wickham's stria, and the lesions of lichen planus are more common in the flexures, and they are associated with a lot of itching. Okay, so that is how lichen planus looks like. Very different from P. rosea when you see the details. Coming to the next question, again a very, very, very favorite topic of the INI-CET exam, sexually transmitted diseases. Every year in every exam there are at least 2 questions from this topic. Okay, very important. Here a 35-year-old multiparous patient with multiple sexual partners presents with a painless genital ulcer. The first test to be done it. So when there is a patient with a painless genital ulcer, what are the differentials? Syphilis and donovanosis. So these are the 2 DDs when you are dealing with a painless genital ulcer, where syphilis is more common, right? So what is the first test that you do if you have a patient of primary syphilis? You do a scraping from the ulcer and you do a dark ground microscopy. Okay, so this is the first thing that you do. And do we have that in the option? Yes, we do have scraping from the ulcer as the first test that you will do here. When you have donovanosis, in donovanosis you take a crushed smear from the ulcer, then you do a zinc stain, which is actually the Giemsa stain, and you look for Donovan bodies, which are the bipolar staining bacteria. For this we make a crush smear. So we actually take a clipping, we take a cut from the ulcer and we crush it between 2 slides, and that is what we use for the Giemsa staining. So this is a thing when you are suspecting donovanosis. On the other hand, in syphilis, you just take a scraping from the ulcer, you see it under the dark ground microscope, and you see the spiral bacteria which are running around. So you actually see the motility also. So the first test that you will do here is a scraping from the ulcer. VDRL you do when you are suspecting secondary syphilis, which is not the case here. HIV ELISA you will definitely do in this patient. You do it in all patients who present to you with a STD. But that will not be the first test. That will happen subsequently. Giemsa stain, once your DGI is negative, if you're suspecting donovanosis, yes, you will go for it, but it will not be the first test. It will be done if your DGI is negative. Okay, so the wording here of the question is very important. The first test to be done, the first test that will be done will be a scraping from the ulcer. This is just an approach to genital ulcer which we have discussed so many times. When the ulcer is painless, you see syphilis and donovanosis as your differentials. When the ulcer is painful, it could either be chancroid or genital herpes. In this case, you see a look at the lymphadenopathy as a further hint. In syphilis, it will be a painless ulcer with a painless bilateral shorty inguinal lymphadenopathy. On the other hand, in donovanosis, there is no lymphadenopathy. So when you have a painless ulcer, just look at the lymph nodes, you will be able to make out the diagnosis. In painful ulcers with chancroid, you may get a unilateral or a bilateral painful suppurative inguinal lymph node, which is also called as a bubo. So in chancroid, you get a concomitant ulcer with a bubo. In genital herpes, there will be a bilateral painful inguinal lymph node enlargement. Okay, so again here the lymph nodes help you in further differentiating between your DDs. This is your general approach to a genital ulcer. Coming to primary syphilis, this dark ground microscopy in primary syphilis is a favorite question asked in the last 3 years in both Neet and the INI-CT. Very, very important genital ulcer disease. Very important. If you get an image, you see this beautiful single ulcer with well-defined edges, with a fleshy, clean surface and a oozy appearance. This oozing is the serum which is full of the treponemes, and it is actually this serum which you take and you observe under the dark ground microscope. You see these typical beautiful spiral bacteria which have a corkscrew motility. Drug of choice for primary syphilis is injection benzathine penicillin, 2.4 million international units, given as a single dose. So this is a single dose that you give in primary syphilis. Okay, so coming to the next question, a lady comes with a white vaginal discharge and yellow staining of the undergarments. There is no itch, no soreness. She is on oral contraceptive pills. The vaginal pH is acidic and lactobacillus is normal. What is the likely cause? So what are the hints that the question is giving us? Number one, the patient has a white vaginal discharge. Number two, there is no complaint of itching or soreness. And number three, vaginal pH is normal, that is acidic, and lactobacillus is normal. So when pH is acidic and lactobacillus is normal, what do you get? You either get a discharge which is called as a physiological, that is a normal discharge, or you can get candidiasis here. Why? Because in the other two causes of vaginal discharge, let me just show you here. In the other two causes of vaginal discharge, which is trichomoniasis and bacterial vaginosis, the pH of the vagina increases. So pH is normal here, that is in physiological discharge and in candidiasis. Now, if a patient has candidiasis, there will be a white discharge, but it will be curdy. Okay, so it will be a white curdy discharge and it will have a lot of itching and a lot of soreness. Okay, on the other hand, when the patient has physiological discharge, yes, there will be a white discharge, but there will be no other complaints. So no itching, no soreness. Plus the pH will be normal and it will be acidic. So what does this match? Which of these two matches our question here? Yes, you tell me. A white discharge with no itching with a normal pH. Yes, it matches this option here, which is a physiological discharge. On the other hand, if this patient had itching and soreness, the answer would have been candidiasis. Chlamydia is a cause of cervicitis. It causes a clear mucoid discharge, but that comes from the cervix. So this is a cause of cervicitis, not the answer here. Candidiasis, I've already told you. Bacterial vaginosis, the pH will be higher, the lactobacillus will be lesser. Okay, so that is also not the answer here. So the correct answer to this question is option D, that is a physiological discharge, and it is also the most common cause of vaginal discharge. So if you're asked what is the most common cause of vaginal discharge, that is a physiological discharge. But most common cause of altered vaginal discharge is bacterial vaginosis. The common causes: candidiasis, trichomoniasis, and bacterial vaginosis. Very important questions on their own and very important to differentiate from each other. Candidiasis, I've already told you, will be a curdy white discharge adherent to vaginal walls associated with itching. Trichomoniasis, on the other hand, will be a greenish, frothy discharge associated with a finding which is called as Strawberry cervix, this was actually a question which was asked previously also, so this is also a repeat topic. And here the pH will be higher, it will be an alkaline pH. Bacterial vaginosis, again pH higher, lactobacillus lower, associated with a homogeneous, watery, foul smelling discharge. Okay, so clinical characteristics of the discharge along with the symptoms and the lab findings together bring you to a diagnosis. Here, since there was nothing abnormal, this is a physiological discharge. Coming to the next question, which is question number 8. A patient here presents with greyish, watery vaginal discharge, shows clue cells on the smear. What are clue cells? So it's not asking you the diagnosis, it is just asking you a few words about the finding here. But first tell me, what is this patient here? What is she suffering from? There is a greyish white watery discharge with clue cells. So where are clue cells seen? Yes, I hope you all know it. This is seen in this diagnosis, which is called as bacterial vaginosis. So we find clue cells in bacterial vaginosis. And what actually are these? These are epithelial cells with bacteria adhered to the cell surface. So these are bacteria which are adhered to the cell surface. These cells are actually the squamous cells which are shedding from the vaginal walls. So this is a finding that you see in bacterial vaginosis. Just a quick revision here. In bacterial vaginosis, what happens is that the normal lactobacillus reduce in number while the gram-negative bacteria increase in number, predominantly the Gardnerella vaginalis, the ureaplasma, and the certain other bacteria. So what you have is increased number of these bacteria in the vagina. So this is not actually an infection, it is just an altered flora of the vagina. Because of this, the patient gets a typical discharge, which is a foul smelling, copious, watery discharge from the vagina. The pH increases. Then when you put a drop of 10% KOH on this vaginal discharge, you get a fishy odor. This is called as the whiff test. And when you make a smear, you get clue cells more than 20% in terms of percentage. So it's not just finding clue cells here. The clue cells have to be more than 20%. Why? Why not lesser? Because Gardnerella are normal commensals of the vagina. They are anyway present in the female patients. So a lot of these bacteria may anyway be adhered to the vaginal squams. Some clue cells you may find as a normal finding also. But when these bacteria increase in number, you get more stippling, more clue cells. That is when you call it bacterial vaginosis. So the criteria says that you should have more than 20% clue cells in the smear. Okay, so this is the Amsel's criterion. When you look at clue cells closely, see, this is a normal vaginal squam. But when the bacteria are stippled on the surface, this is called as a clue cell. So these are all the clue cells. You see the gram-negative bacteria stippling on the squamous surface. Treatment of choice for bacterial vaginosis, you give metronidazole. So the treatment of choice is metronidazole. Now coming to question number 9, identify the following lines. Through all my discussions, I've been telling students since a while that these lines in dermatology are very important, and very important to actually differentiate 3 lines from each other, which are the Blaschkold lines, the dermatomes, and the relaxed tension line, which are also called as Langer's line. Very important, even though they had forgotten to ask this question over the last 3-4 years, but prior to that, this used to be a very important question. Okay, now look at the image here. What do you see in the image? In the image, you see these straight lines in different directions over the body. So it's as if there's a mummy with a bandage wrapped around it. Also, this is a diagram that you might have seen commonly in your operation theaters. You know, this printout it's stuck on the wall of the OT. Why? Because these lines are used to decide the incisions that you give during a surgery. What are these? These are nothing but the relaxed skin tension lines we call RSTL, also called as Langer's lines. These are lines along which the collagen fibers are oriented, so they are parallel to the collagen fibers in the skin. This was a question also asked in Neet 2016 or so, a question on the Langer's lines. So these are along the collagen fibers parallelly, and this is how you have to give your surgical incision also. It has to be parallel to these RSTLs. If you give an incision perpendicular to these, the scar will not heal. There may be gaping or a risk of a hypertrophic scarring. So for a good healing, a good scar, the incision has to be parallel to these RSTLs. And another important point which was asked in the Neet exam, do these lines remain constant throughout the life? No. The skin changes, it becomes lax with age. So the orientation of the collagen fibers changes with age, and so do these RSTLs. So they don't remain constant through life. They can change as per the orientation of the collagen fibers. They are not constant. So these are just some important points about Langer's lines that you should know. But another thing that you should know is how to differentiate these three lines from each other. So look at this image here. You have the image of Blaschkoid lines, the dermatomes, and the Langer's lines. When you look at the Blaschkoid lines, they will always have a midline demarcation. So the Blaschkoid lines will have a midline demarcation, and the shape of these lines will be different along the different areas of the body. So number one, a midline demarcation. Number two, a different shape on different areas of the body. These are actually the lines of embryonal migration of the skin cells. So the shape is different on different areas of the body. That is how you identify Blaschkoid lines. When you come to dermatomes, again there will be a midline demarcation, but these lines will be straight. Wherever you see whichever side of the body, these will always be straight lines with a midline demarcation. So that is how you can differentiate the Blaschkoid lines from the dermatomes. Coming to the Langer's lines, this actually looks like a wrapped mummy to me, because it has different orientation on different parts of the body. So imagine being an Egyptian mummy wrapped in bandages. That is how these Langer's line look to me. So you look at this image, three images together, you identify these lines from each other, differentiate them. Very, very important. Another question that comes is the dermatosis along the Blaschkoid lines. Here you have the epidermal nevi. Then we have incontinentia pigmenti, and we have hypomelanosis of Ito. So these are the different diseases that can appear along the Blaschkoid lines. Along the dermatomes, we have herpes zoster, and the Langer's lines are for the surgical incision. So this is very, very important. The fourth option here, the marionette lines, these are actually the droops that you see on the face with aging. So these are lines which run from the lips down. So these are marionette lines. These are just signs of aging on the skin. They are seen on the face, drooping of the lips. So these are the marionette lines. With this, we finish our discussion. I hope all these questions were clear to you. And for the students who are yet to give the exam, please make sure that you are well oriented with these previous year questions, because they actually form a very important basis of your preparation for all your future exams. Okay, any doubts, you can put them in the comments or the Telegram group. We'll be more than happy to answer them. Thank you. All the best for your exam.